Everybody, welcome to yet another episode of the Core Consults RX podcast. Cole and I get another accredited episode coming your way.
Yes.
And it's one that I don't think we've covered in a while, outside of like a patient case maybe.
Years and years and years.
That long?
Years and, yeah.
Wow.
At least 3.
Okay, right on. I guess that's technically right then.
Actually, it's been 5.
Is it really?
Yeah, oh yeah.
Is it one of our first episodes?
Yeah. Well, probably in the top 30.
Okay, well.
Which goes to show how long we've been doing this.
So long.
So long.
You'd think we'd be a lot more successful.
I know.
Maybe we're not that good at it.
You'd think we'd learn more.
Yeah, that's true. But if you haven't figured it out already, I'm sure you have. But we're obviously talking about smoking cessation tonight.
If you weren't thinking that, then what's wrong with you?
Yeah, then, well, that's the title.
I just got a notification that we went live.
Oh, did you? Oh, cool.
Nice?
That we went live.
Yeah.
That is nice. So we're going to be doing smoking cessation. I just kind of doing a review of the pharmacotherapy. This is an accredited episode, so for those of you who are free CE members and have unlimited memberships or their gold or platinum memberships, then you already have access to all of the accredited episodes. And so if you listen to the podcast, you'll go and take the post-activity test, which is a 10-question multiple choice test. Go through that, and then you'll get your 1 hour of continuing education credit for pharmacists and nurses. So we will give you a super secret password at some point during this episode, and that will be your ticket into taking that post-activity exam.
It will.
And then
We really should set some sort of alarm to remind us to do that.
I know, I feel like we've forgotten a couple times.
You know, since we're live, we could just tell somebody to let us know halfway through.
That's a good idea.
Like 20 minutes.
Somebody let us know.
Just tell us.
But if those of you who are not free CE members, obviously, if you can't get the credit, check out their website. They have a whole huge library of monographs, live CEs, the podcast episodes that we've done. They have mini CEs, all kinds of different stuff. So they have a great library to choose from, lots of learning opportunities. So definitely check out the website and become a member if you're not, so you can listen to our podcast and actually get credit for it.
Yes.
So thanks to Free CE, as always, for continuing to partner with us. And let's get rolling, I guess.
Let's get rolling. So we're going to start off with a little bit of pathophysiology of cigarette smoking. Of course, you can get nicotine in various forms, but the most traditional way is through cigarette smoking or through smokeless tobacco. Usually what we're talking about is trying to quit cigarette smoking. So what does cigarette smoking do in the brain? Why is it addictive? And why do the things that we have to treat it help? Cigarette smoking and the nicotine associated causes direct stimulation of the nicotinic acetylcholine receptors, which leads to stimulation of dopamine in the mesolimbic pathway. And so you hear a lot about the kind of the dopamine boost that you get from smoking a cigarette. Of course, this is affecting the reward pathway, can cause mood elevation, appetite suppression. So frequently patients will lose weight from smoking, or at least when they stop smoking, they'll probably gain some weight. Mm-hmm. After exposure to nicotine, those acetylcholine receptors are blocked for a short time. Both nicotine and acetylcholine are blocked from binding at that time. There's no stimulation of the mesolimbic dopamine receptors during this brief period of time. So chronically, tobacco use can lead to excessive upregulation of those nicotinic acetylcholine receptors to compensate for that. So dopamine receptors are downregulated due to excessive dopamine stimulation, and this can cause other issues that we'll talk about.
Yeah, and so we know that obviously, besides the addictive side of nicotine, it also has various physiological responses as well. And so, for example, nicotine can cause the stimulation of adrenal glands and epinephrine release. So the overproduction of epinephrine is going to eventually lead to cardiac changes and increased heart rate and increased blood pressure over time. Nicotine also will stimulate the release of glucose and insulin suppression, and so you tend to have situations where the patient may have more frequent hyperglycemia, or at least harder times controlling their blood sugar in some situations, where especially with excessive nicotine use. Frequent fluctuations in dopamine, obviously, like Cole was saying, can lead to periods that affect the patient's overall, mental health and well-being. And so the patients, when they have these, fluctuations in dopamine, they're getting these periods of, strong stimulation and that, like Cole was saying, the reward pathway of all that dopamine release. But then as those levels start to go back down again, it can lead to fatigue and, feelings of depression and lack of motivation and that type of thing. And this kind of back and forth fluctuation can definitely lead to an increase in the frequency of tobacco use because you're trying to overcompensate for the lack of the dopamine response. So the number of cigarettes per day starts going up, and there you go. It's a vicious cycle.
Right. So in the brain, that's part of the reason why it has addictive properties. But it's multifaceted as to the addiction process, which doesn't just apply to nicotine, also applies to other types of addiction like other drugs and things like that, which is that there's this physical addiction happening in the brain along with the withdrawal symptoms and the need to avoid those withdrawal symptoms. And then there's the behavioral component, which is it being habit forming in some way. I think this is particularly distinct with smoking. And within that, you get this kind of conditioning response every time that you smoke that can be associated with certain activities, for instance. So if you normally, have a cigarette with your morning coffee, then you're going to associate your morning coffee with a cigarette. If you have a cigarette while you're driving in the car, then you're going to associate car rides with a cigarette. Same with breaks at work and things of that nature. So part of the multifaceted approach to treating the addiction is avoidance of those triggers or finding some way to compensate for those triggers that are going to increase your risk for having a craving at that specific time.
Yeah, absolutely. And have you talked to anybody who it wasn't even the fact that they were craving the nicotine? It was literally just the habit of being in the car, sitting in traffic. That's just been their thing they've done for ever, and that's just that hand to mouth type of movement is just become ingrained in their schedule.
I mean, I think everybody can relate on maybe a less significant level with food. You associate
or caffeine.
You associate stressful times with like eating something, or maybe for me it's always if I'm just laying there vegging out in the evening after my kid's asleep, then I'm just going to go grab a bag of chips and just start munching on some chips. And that is the reason why I'm unhealthy, is because I do great all throughout the day, and then 8:30 comes and I sit on the couch and start eating chips.
I'm glad you brought it up because I didn't know how to broach the subject. I was just like, hey man, have you thought about taking a statin?
I did actually get my blood drawn like 2 weeks ago. This is the
cool.
results.
They blew your vein. That's
my
nice.
vein, and my cholesterol was a teensy bit high.
So
I'm trying to make some changes. It is the chips. The chips, I mean, if you look, it says no cholesterol. I mean, it's multifaceted.
I was going to say, I think that's your word of the night, by the way. It's good. Multifaceted.
Is that the third time?
At least.
It's multifactorial.
Oh, no.
So I got to make some changes.
Yeah. I don't know if the cholesterol in the diet nutrition label correlates directly with LDL production.
Not necessarily.
But, it's,
in my mind, I'm like, oh, look,
they
got
are,
no cholesterol.
It's good to go.
Yeah.
These Doritos are good for me. So nicotine addiction, there's a difference between someone who, not that it's, we're advocating for any even social use of cigarettes, but the difference between someone who's using, or smoking a cigarette just out with friends, but then doesn't actually continue that, at home versus like nicotine addiction. Really the addiction aspect is characterized by the specific withdrawal syndrome that's associated with stopping, the nicotine. And so the kind of first sort of signs and symptoms are going to start developing pretty quickly. Within the first few hours to 12 hours of smoking cessation without any other type of supportive therapy or anything, the patient's definitely going to start having those withdrawal syndrome symptoms starting to occur. Craving for tobacco in general. Patients can be really irritable. Sometimes, patients can be more likely to have, aggressive tendencies or they can be more anxious, depressed. Like Cole mentioned, the increase in appetite can, be definitely alarming to patients who have struggled with keeping their weight off or, maybe just recently lost some weight. They can have difficulty concentrating, headaches, insomnia, dizziness, vertigo, so depending on any kind of like comorbidities they may have, you can really exacerbate a lot of different issues and overall just make it for a very, very uncomfortable process of trying to get your body off of that nicotine. The symptoms, the manifestations of, withdrawal are temporary, but, they're going to potentially reach their greatest intensity within the first 1 to 3 days. 3 to 4, weeks, they still can be present in as many as 40% of patients. So it's a long process of trying to, go through this withdrawal, this withdrawal process and get this, your body back to baseline. And it's, important, especially if, I don't know why you would want to do it without assistance with pharmacology, but if you have a patient who does, just kind of being upfront with them, and even the ones that are going to have supportive care, being upfront that this is going to be a tough road, and just give them realistic expectations.
Yeah, it's not pleasant. There are a number of tools that you can have in your tool belt to assist with that, because we're going to talk about the medications and the nicotine replacement therapy, but a lot of it is behavioral, and a lot of it is meeting the patient where they're at in, assessing their readiness to quit. My granddad smoked for like 48 years. I think he started smoking when he was like 12 years old,
Nice.
which is just crazy.
It's a different time.
Just a different time. But I think he had something done, and it turned out that he had some sort of heart disease or high cholesterol or blockage. I can't remember exactly what it was, but
Sounds hereditary.
he was like, "What do I need to do?" And the doctor's like, "You need to stop smoking." So he stopped smoking.
Just like that?
No NRT, no meds, or
Didn't
anything
need
like
it.
that.
It's a different time. Different generation.
Different
Much
generation.
stronger generation.
Yeah, they could do stuff like that. But of course, not everybody can. And what's the number of times that people always say it takes like 7 attempts on average or something to quit? Or it takes multiple attempts. You never heard that?
I can't think of what it is though, and I'm gonna say the wrong thing. So
I'm not gonna say. Well, who knows if that's even what's that based on? But the idea is that it takes multiple attempts.
but it's cool to say it. Makes
Yeah.
you sound very insightful.
I suppose.
If you do it 7 times, you'll be an expert.
If you say it without conviction in your voice,
Right.
then it doesn't sound like
It
you know what
sure
you're talking
doesn't.
about. But it takes multiple times. So the point is, we're going to give you over the next few minutes some things that you can use. It's a couple of acronyms and some tools that obviously you're not going to memorize by listening to a podcast, but it's really just to kind of give you some insight into some things to be thinking about as you're addressing these patients.
Some psychology.
It's like psychology
models.
Yeah,
if you will.
psychological
Counseling.
models.
Yes, those words.
So one is called the 5 A's model. So as you can imagine, there's going to be 5 words that start with A. It's going to follow up with something that you should be doing. And these are 5 steps that are usually needed to treat tobacco use and dependence in a clinical setting. And they are ask, advise, assess, assist, and arrange. I think that was 5.
Yep.
5 A's. So firstly, we're going to ask about the tobacco use, which is meaning identify and document tobacco use status for every patient at every visit. So you'll see this in notes all the time, that it's addressed, or at least being documented that it's addressed. But the idea is just to be asking every time that they are interfacing with a medical professional, that we ask them about their willingness to quit. Then we advise quitting in a clear, strong, and personalized manner. Urge every tobacco user to quit at every visit. And then, based on that, you can assess if they are willing to make a quit attempt. And we'll talk about the trans-theoretical model of change. The amount of times I've heard that phrase in my life
Sounds important.
makes me want to fall asleep.
Oh, well.
But especially the word trans-theoretical. Where else do you hear that except for in this?
Well, it doesn't sound like
model.
you're very ready to accept change in your own life.
I
You
think
might want to do some more searching.
I'd be on the early phase of the trans-theoretical model. I digress. So you want to assess the willingness to quit. So are they willing to make a quit attempt? Because if they're not, odds are it's not going to be a successful attempt. If they are willing, you're going to assist them in the quit attempt. You're going to offer medication, provide or refer to counseling or additional treatment to help the patient quit. And then if they go forward with that, you want to arrange follow-up for a patient willing to make a quit attempt, provide follow-up contacts beginning the first week after the quit date. So you'll want to establish, maybe they're not going to quit that day. Maybe they need to get the medications in order. Maybe they have some things going on. You want to ask them for a specific quit date, which kind of makes them, it's almost like scheduling it. It's like making a commitment. And then
it's almost exactly like scheduling.
It is scheduling it, and it is making a commitment. And then you tell them, I'll follow up with you, or somebody will follow up with you at this given time to see how you're doing, and to kind of hold you accountable. To sort of hold you accountable.
Right.
Or to literally. I'm trying to avoid, you know how people get annoyed when you say literally all the time? So instead I just say sort of. I think those are totally different.
Those are very different words. I think maybe we need to find a different synonym.
Maybe I should just avoid qualifiers.
Yeah.
In every sense.
That's true. But, they're easy to throw in there.
Yeah. I like to hedge,
I hear you.
I'm a hedger.
Oh, big time. Yeah. Sometimes I just keep on talking until I just feel like I've just bored everyone to death and they can't possibly be focused anymore.
So that's the 5 A's model.
Yes. So this is the one thing I have with the 5 A's, and we'll get into the 5 R's next, which I feel like I like that one. I like that list better.
A little further down the alphabet.
Yeah. A little bit more my style, I think. But the advice quitting, this whole idea of like in a strong, personalized manner is good, I guess. But urging, the patient to quit at every visit. My personal philosophy on that is, it depends on the patient's personality and all that. But the patients that clearly don't want to be lectured about it, it drives me crazy when I hear people like, well, smoking is really bad for you. They know. They've heard. So it's just, that part of it drives me crazy. I feel like I end up kind of either to show them the harm or whatever, I'll use like the ASCVD risk calculator, kind of like with smoking versus without smoking or something along those lines maybe, but they all know it's bad for your health overall.
They do, so, and I think the calculator is a great thing. And I think the third R in the R's model is, I think, a more positive approach. Yeah. Especially depending on what's been tried, right? You probably know your patients, but I think sometimes you can attract more flies with honey, as it were.
Dude, we're filled with all kinds of anecdotes and quips tonight. So the 5 R's. So let's get into this model, which is a little bit different than a little bit better than Cole's T model, but the A model. What am I saying? I'm thinking of trans theoretical. But so the 5 R's: relevance, risks, rewards, roadblocks, repetition. So what is the relevance of quitting to the patient? Which I'm a big fan of, obviously, of making things very patient specific, and this kind of goes back to that whole motivational interviewing, and which you guys know I'm not a big fan of that term, but I like the tactic. And
you just don't like labels.
I just hate the label of motivational interviewing.
You like everything else about what it is.
But
you just
let's
like
call
calling
it.
it
Just
that.
call it talking to somebody.
Kind of like how I don't like the label trans theoretical model of change.
Yeah.
I like the model. I just don't like what it's called.
You like the theory.
Yeah, the theory.
But asking the why, kind of why. And this is more so obviously for a patient who may be contemplating, quitting. So if you have a patient that is willing to kind of admit the why it would be beneficial to their health or beneficial to them overall for setting a quit date and actually getting off of the cigarettes, then that can obviously help with their buy-in and kind of lead them along that path of them sort of taking charge of their own quitting process. But the risks, again, I'd say I'd take that with a little bit of hesitation because they know the risks at this point. We all have the internet. We're all aware of those risks. So I feel like beating that over, over and over again is kind of irrelevant. But
you'd be hard pressed to find somebody scratching their head saying it really increases my risk for heart.
It does what? I thought it was like super good for me. But the rewards of quitting, whether that be the patient's ability to just have better like lung function and quality of life from maybe an exercise potential standpoint or something, or just overall longevity, getting their blood pressure down, and some of those types of things that maybe they can reduce their medication burden, whatever it is would be something that would be beneficial to that patient and they would find value in is obviously what you'd want to kind of schedule the quitting, I guess. The what's the word I'm looking for? Like the idea of quitting, the motivation behind quitting, kind of.
You know what would motivate me?
What? Oh no,
the money.
The money? Oh, that's
the cost.
True. That's
true.
True.
Man, I will do whatever I can to save 4 cents.
Right, but you're the guy.
Cigarettes are expensive.
They are, but yeah, again, I think that's kind of in the same like camp of.
They know the cost.
Yeah.
Yes, I know.
They're like me when I go to hibachi. I'm gonna get the shrimp. Whereas you're like, I'm $1 extra for shrimp. They're not that good.
It's $1. It's way more than $1.
I don't know how much it is.
True hibachi, but in my hibachi places, yes, it's only $1 extra. And no, I do not.
And you still don't get
that.
it, so there
Absolutely
you go.
not.
Yeah, no, you're not going to be a good candidate.
There's got to be other people out there like me who, if we were like assessing the whole budget, they'd be like, I can save how much by not doing cigarettes? I mean, that would motivate me significantly.
Yeah.
But yes, they obviously pay for them every time. They know how much they cost.
They do.
Yes.
Roadblocks, what issues they may have, or barriers to quitting they may have in their own life, whether it be concerns for mood changes or weight gain or whatever. And then obviously the repetition with respect, obviously approaching the topic when you feel like you're not being obnoxious about it. Obviously, if the patient's starting to push back a little bit, then you want to still keep that rapport with the patient. But so there's some letter models for you.
Yes.
You want to go through the actual
Fagerstrom
and see how dependent these patients are?
I will, but first I want to address a couple comments in the chat, which I really appreciate. So somebody must have obviously seen that I was searching for a word, and the word was colloquialism earlier. When you
I think
said,
that's my dad, actually. Yeah, he's on LinkedIn.
When you said we're full of like anecdotes and things.
Quips, yeah.
I was about to say something.
I couldn't think of the right word, yeah.
Colloquialism?
Colloquialism.
Nailed it.
Yeah.
Also, Jeremy says, love the podcast. It's been a great resource to spike interest during pharmacy school. Hope you guys touch base about the Eagles trial and findings regarding neuropsychiatric events, which, foreshadowing.
Way to go, Jeremy.
Thanks,
we like
Jeremy.
it. We always looking for the foreshadowing.
Yes.
And then what is my buddy up there, Vinny, says, Corvino, let's go. I'm ready to learn.
Ready to learn.
He's one of my former PA students on to much better and greater things now.
Love it. Okay, so another tool which doesn't have a whole lot of maybe usefulness clinically, but is interesting and used a lot in studies. I think, I don't know if it correlates, but I would use this to say, like, how dependent are they? If they're extremely dependent, maybe we're going to have a little tougher time with quitting. I don't know if that bears out in studies, but that's what I would think.
Kind of using it just to kind of give yourself an idea of what the road ahead is going to look like potentially.
Yeah. So this is called the Fagerstrom test for nicotine dependence, and it looks at a few items related to how dependent on a scale from low dependence, low to moderate dependence, or high dependence, and it asks a few questions. The most significant of them being, how soon after waking do you smoke your first cigarette? Within 5 minutes, 5 to 30 minutes, or 31 to 60 minutes. And this is important because, of course, as they're sleeping, the nicotine is worn off. And when they wake up, if they're pretty dependent, then they're probably going to be craving that cigarette soon. If their dependency is less, then they could probably go a little longer before it ticks in their mind like, ooh, I need to smoke a cigarette because I'm starting to get some withdrawal symptoms. Mike mentioned 4 to 12 hours, right? So, you might sleep 4 hours like Mike, you might sleep 12 hours like me. Regardless, you might have some symptoms.
If you average it out, it's 8.
Yes, so we average out to a normal human being. The next question is, do you find it difficult to refrain from smoking in places where it's forbidden? Church and library, that was interesting examples. I'd imagine a hospital would be a pretty obvious example too, but
airplanes,
good example.
It's frowned upon.
Airports.
I like that they use the word forbidden.
I know.
That's harsh.
That is very harsh.
Let's just say that you will be in jail forever if you smoke, and you're still going to do it. How dependent are you?
I'm trying to think of some other places where you can't smoke. Restaurants now. I mean, do you remember
movie theaters? I feel like,
theaters?
Yeah, pretty much.
Do you remember growing up? And I mean, they had smoking and non-smoking section,
which is insanity.
And the wait was always longer for the non-smoking.
Of course. Yeah.
So it's like sitting indoors or outdoors. It was like, so we got a 30-minute wait in the non-smoking, but you could sit right here in the smoking section. It's like, all right, I'll give my kids secondhand smoke lung cancer to not wait 20 more minutes for my chicken wings.
We got plenty of things to treat asthma now, so it's fine.
I remember going into TGI Fridays and sitting there in the smoking section, just
nice.
Like, oh man, there's a lot of smoke over here.
Yeah, this is hard to breathe over here. Yeah, that's funny. It's an indoor building, and they have like some areas that smoke and some not. Like,
I know, as if the non-smoking section was totally smoke free. Like the smoke is permeating over there too.
What year were they finally like, this is a dumb idea, right?
I don't know. It must have been the early 2000s
or late 90s.
I mean, I can remember this, and it must have been the early 2000s.
Yeah, it must have been. Because you were born in like 95?
Yeah, like 94.
94?
Yeah. Thanks for telling everybody my age.
I mean, whatever. I've said your age on this thing like a million times.
Yeah, just joking.
It's fine. We won't hunt you down.
Yeah, so it must have been around then. Anyways, they also asked the question, which cigarette would you hate to give up, the first in the morning or any other. It's kind of related to that, early morning
The one right
cravings.
after work or
Yeah.
traffic.
How many cigarettes a day do you smoke? 10 or less, up to 20, up to 30, or more than 30. It's kind of how they stratify it. And we'll kind of talk about pack per day calculations. Do you smoke more frequently in the morning? And do you smoke even if you're sick in bed most of the day? So really 3 of these 6 questions are related to morning cravings. And so, yeah, that's the Fagerstrom test for nicotine dependence.
Yeah, so like Cole said, you'll see, that listed in patients' charts and whatnot, but technically speaking, it doesn't have a super great clinical utility, I guess. I'm sure there's people that argue that with me, but it definitely has its purposes for research and whatnot. There's also things like the heaviness of smoking index, which is a 2-item questionnaire that we're taken from Fagerstrom's test, and it can be used clinically as part of like the new guidelines and whatnot, where they say low, medium, and high dependency or heaviness, I should say. So 0 to 1 is low, 2 to 4 is medium, 5 to 6 is high. So a little bit quicker, test questionnaire to fill out and get an idea of their dependence in a more timely fashion, I guess.
Yeah.
So pack year history. That's the other term you'll see thrown around. This is one that I do end up typing quite a bit in my chart, although it's used very commonly. However, as far as like the clinical outcome and like whether or not that means anything, it really doesn't.
I mean, it's very subjective and quite an estimate.
Yeah,
it's quite an estimate.
Quite. Well, so you're calculating based on the number of years the patient smoked.
Patient reported,
times the packs of cigarettes per day.
Patient reported.
There you go. So if the patient, for example, has a half pack a day for 10 years, their pack year history is 5. So see how that works? But again, if somebody has a pack year history of, say, 50 or whatever, and then versus somebody who has a pack year history of 5, the person that has a pack year history of 5 still could end up developing lung cancer first or COPD or something. It doesn't necessarily correlate with outcomes or negative outcomes, but it does give you an idea of
It just kind of gives you an idea.
That's
about all it does.
How, again, I think it's all piling all this information together so you can know how intense you have to go with the supportive therapy or what have you.
It paints a picture.
It trans theoretical picture.
Speaking of which, my favorite.
There it is. I just laid it up for you, dude.
The trans theoretical model of change. I remember when I first learned about this, it was first year pharmacy school, and maybe it was referenced in a psychology class before
you probably
that.
heard about it.
I might have, but just didn't pay much attention. The first time I actually had to study and understand it was first year pharmacy school. And I don't remember who that professor was, but man, that was a boring class. Mm-hmm. It was a boring class. So every time I see this, I'm like, oh my gosh, this is so boring. But it's really not that complicated. Michael laid out for you, but I'll kind of give you the short version, which it's assessing how ready. In this instance, it's used in a whole variety of things throughout in your life that you could apply this in psychology. But in this instance, it's really assessing how ready someone is to quit, which we know if they're not ready, they're not going to quit. It categorizes patients to help clinicians know what treatments or therapies to offer. And the categories are the pre-contemplation phase, the contemplation phase, the preparation phase, the action phase, and the maintenance phase. If you had to make an algorithm, it'd be pick a Pam.
Yep. An algorithm or an anagram? We're really...
Or not an anagram, a acronym.
Mnemonic.
No, it's an acronym.
Oh, God, we are so dumb. Okay. Can you tell we didn't do great in English class?
Yeah. Is that an English class?
Probably.
I guess.
I don't know.
I wouldn't
have remembered it. I don't think you talk about that stuff in spelling class, but I could be wrong.
Yeah.
So pre-contemplation, there's basically the patient. You're sort of just kind of weighing out the benefits and risks, starting that conversation. There's no quit plan. Within the next 6 months, the patient is not seriously considering quitting or anything like that. When you transfer over to the contemplation phase, that's where there is a quit plan that's kind of laid out for within the next 6 months. They're obviously seriously considering going forward with this plan. And, at that point you're using motivational interviewing and still just kind of keeping them on track for their quit date. Their preparation, phase is where their quit plan is coming up within the next month. They start making some of these behavioral changes. Maybe they change where they go in the morning to drink their coffee to kind of start breaking habits of just, behavioral habits like that. Assessing their dependency and, which medication options, could be best for that patient to kind of get everything ready to go so that when they hit the action phase at their quit date, then that's the goal is the first 1 to 6 days of being tobacco free. So having them, obviously stay on their medication, managing their withdrawal symptoms, making sure that they have support from friends, family, or provider support as well. Some patients will benefit from kind of going through a quit diary and actually kind of, documenting some of their progress as they go through this process. And then maintenance is, after that initial, quit date and first week where they're actually maintaining their smoking cessation, and hopefully at this point they're still having that support, but you can start the process of maybe even tapering off the medications and moving towards the final outcome, which is them being tobacco free.
We should point out that this is probably the best thing that anybody could do for their health,
probably,
which is another thing that I guess everybody knows,
right.
But it's significant. Like if you're talking about diabetes care and addressing all these things to decrease cardiovascular risk and adding on this medication, that medication. Quitting smoking is the best thing you can do.
Big one.
Okay, so there's another treatment algorithm that's helpful that I'll briefly go through that I think is a little more practical. And it kind of coincides.
Yeah, it's kind of just a mixture of all.
It's kind of a mixture. It's got a little bit of the 5 A's, it's got a little bit of the R's, it's got a little bit of the trans-theoretical model. But it's really about initially asking about the tobacco status and if they're a current smoker. Are they smoking daily? Are they smoking non-daily? We're assessing the dependence based on the number of cigarettes per day and their time to first cigarette, and then asking about their prior experience trying to quit. So none of the other ones that we talked about really talked about that, but you need to, have you tried to quit before? How many times? Where'd you get? What'd you try? Was it successful? Then we're going to talk to them about quitting and giving advice and focusing on the benefits of decreasing the risk for cardiovascular disease, then offering treatment, either behavioral or prescribing a med. And if they accept, then we're going to follow up in a couple to 4 weeks and monitor for response and adverse effects and that sort of thing. If they decline, we're going to follow up at the next visit. And then depending on if they're a former smoker and maybe they're in the maintenance phase, we're going to assess relapses and that sort of thing. This is called the pathway for tobacco cessation treatment.
Mm-hmm.
We just gave you a number of tools.
Yeah, probably more than you needed, but that's okay.
Yeah.
Because now we're going to talk about treatment. But before we do,
nice.
We're going to give you guys the secret password. So make sure you write this down or remember it. But today's password is no smoke. We were going to make it smoke, but then we realized that's kind of a weird password. So we made it no smoke. All capital letters, one word. That's the password, no smoke. All one word, no space. So there you go. So we're advising you not to smoke.
We were thinking about making...
Not throwing in some subliminal advertisement, smoke.
Actually, I won't even tell what we were thinking because I don't want to confuse anyone. But
yeah. It's no smoke. We went through about a dozen before we hit record.
It's no smoke.
All right. So treatment options. The most commonly used treatment options, varenicline, the various forms of nicotine replacement, and then also bupropion is another commonly used medication as well. And we'll talk about maybe a place for like tricyclics and things at the very end. But the varenicline tends to be one of the main medications that we think of when we think of smoking cessation. And it's got kind of a unique mechanism of action. So it's a partial agonist antagonist, meaning that basically the varenicline is sitting on the nicotinic receptor, blocking nicotine from being able to bind. And so if you smoke, with Chantix in your system, it's not giving you that, release of dopamine, that reward sensation.
Right.
But it's still allowing for some of that dopamine to be released so that you're combating the occurrence of those withdrawal effects. So that's where the antagonism comes from. So it's blocking, but that partial agonist, you're not getting the same response that you would from nicotine, binding to that receptor, but you get enough to stop the side effects, or the withdrawal symptoms, not the side effects. The adverse effects from the actual varenicline, the most common complaints, and these are dose dependent because there is a starting dose and then they go up to the 1 milligram tablets, but nausea, roughly about 16% of patients will say that it can cause some nausea, that especially at the beginning. Sleep disturbance is reported in about a fifth of patients as well. Headache is another very common complaint with varenicline, but definitely a very commonly used medication. And, as far as like how to administer the medication, counseling points, some things to keep in mind, obviously take it with food and a full glass of water. That can help cut down on some of the GI complaints. And then, making sure that patients are aware that the nausea and headaches, things typically will diminish over time. Your body gets kind of used to the medication, and hopefully, the patient can tolerate it going forward. And then also, patients that are experiencing those, really vivid dreams, because they can either be described. Some patients will have very like vivid, pleasant dreams, and then other people will have, very terrifying dreams and nightmares. And so patients who especially have like a history of PTSD, that are already dealing with nightmares, they are going to potentially, be more likely to experience this from the varenicline as well. But if you do have a patient that is feeling like the varenicline is helping them quit, but the nightmares and dreams or what have you are being, bothersome to their sleep quality and all that, then have them take the second dose instead of taking it more in the evening. Have them take the second dose at 3 p.m. And so they take the first one with breakfast, and then taking the one with dinner like it normally would be is basically the drug's peaking around the time you're going to bed. So if you back it up a couple hours, then it's already peaked in your system, so that it's starting to decline as the patient's going off to sleep. Hopefully, it's not a sure-proof plan to take care of the nightmares, but it can help. Right. And it's not like a drug that needs to be metabolized, so there's not like drug-drug interactions that we're all too worried about.
Right. So as far as concerns with Chantix, it's not a new drug. Back in 2009, the FDA requested that Pfizer add a box warning related to neuropsychiatric symptoms, including suicidal ideation, mood and behavior disturbances, and depression. They since removed that box warning in 2016, and this brings us to the Eagles trial, which Jeremy referenced. Do you want to tell them a little bit about that?
Yeah, basically just showing that the risk for patients that are being started on varenicline that have schizophrenia, neuropsychiatric events, that it's not going to worsen their condition. We would avoid varenicline previously in those because we didn't want to cause worsening of their symptoms. But after that study was done, they realized that it can be done safely. And so without going into too much detail, just because I'd have to review it myself, they basically had enough data to support the removal of that box warning.
Yeah. Okay. So that's varenicline.
Jump into some of the nicotine replacements.
Talking to some of the nicotine replacement therapies, which is what you think it is, which is to help curb...
It's replacement of nicotine.
Replacement of nicotine, and it's a therapy. To curb the cravings associated with quitting smoking. And over time, because instead of, you don't want to just replace smoking with having to chew nicotine gum or use a lozenge all the time. Over time, it has a process where it might assist tapering them down until it gets to a reasonable degree, and they're not going to have such significant side effects. So there are a number, actually, of dosage forms. Nicotine patch, everybody's probably heard of and seen iterated in many instances in media and film and that sort of thing. But it comes as a 21 milligram patch, a 14 milligram patch, and a 7 milligram patch. There's also the nicotine gum. There's a 2 milligram gum and a 4 milligram dose gum, a lozenge in 2 and 4 milligrams. There's a nicotine inhaler with a 10 milligram cartridge, and there's a nicotine nasal spray, which is 10 milligrams per ml. The cartridge, or I should say the inhaler and the nasal spray, are prescription only. The patch, the gum, and the lozenge can all be purchased over the counter. As far as cost goes, the gum and the lozenge are probably the cheapest options, though are usually somewhat adjunct to like the patch, which if you're buying over the counter, for some people it might be, I don't know, $20-$30, a little bit for having to have it for a while. Some don't really like paying that much for it, but the inhaler and the spray are a little bit more pricey too, but their prescription might be covered by insurance.
I feel like the last few times I've tried, because I don't do a ton of smoking cessation like in clinic, but the few times that I've done the patches or even the gum, I think with just the Medicare plans that they've approved them.
Yes, some plans will approve it. Some plans have certain NDCs that they'll approve, so you might have to play around with it a little bit with the billing. But yes, they can be covered.
So in the chat, we see from Vinny asking, what do you know about the physiologic changes in tendons with smoking and reduced healing time with tendon reconstructions? So I need glasses, I think. Uh, just reduce surgical healing in general. So yeah, I think, and I'm by no means some expert on this, but I think basically because you can get that the blood vessel narrowing and constriction, that reduced blood flow tends to reduce the rate of oxygen delivery, nutrient delivery, and so overall it's going to definitely delay wound healing, I think in general, which I would imagine that would kind of trigger over into the or fall over into the tendon space. But the other thing would be having some kind of a immunosuppressive property to it. So the risk of infection, I imagine, would be higher in a patient who's smoking as well.
I'd imagine.
So that's my just off the cuff ignorant response there, Vinny.
Well, I probably wouldn't have had one, so good job. LB also says, love the podcast. For the next one, are you guys able to update guidelines for asthma and or COPD?
Yes, we got to do
that.
Update on those.
Yeah.
It's coming up. I got to teach both those sections for the PA school here in about 3 weeks, so
that'll coincide.
We'll have to be updated. All right. Do you want to? You want to go through the?
Yeah, I'll go through the patch a little bit. So I mentioned the patch comes in 2114 and 7 milligrams, and it's not always a natural start with 21, then taper down to 14, then taper down to 7. It kind of depends on how dependent you are, how many cigarettes you're smoking. And I guess that doesn't really necessarily relate to how dependent you are, but it relates to how much nicotine your body's used to through the cigarette and how that might equate to the patch that you're going to get. And on the boxes is going to be the appropriate instructions for the patients to follow. So that's why it's OTC. They could do it themselves. But it's good for you to know so you can talk to them about it as well. If, say, they're smoking more than 10 cigarettes per day, then they would start with the 21 milligram patch, and they would use that daily for 6 weeks. And we'll talk about how to apply that and some nuances there. But they would use that daily for 6 weeks. Then they'd go to the step 2, which is the 14 milligram patch. They'd do that for 2 weeks. And then they would go to the 7 milligram patch, and they would do that for 2 weeks and then hopefully stop. If they're smoking less than 10 cigarettes per day, they would skip step 1, the 21 milligram, and go straight to step 2, the 14 milligram. They would use that for 6 weeks, and then they would go down to the 7 milligram for 2 weeks and hopefully stop after that.
And for those, I don't know if we mentioned it already, but a typical pack of cigarettes is going to have 20 cigarettes with roughly 1 milligram of nicotine each. So a pack of cigarettes is 20 milligrams roughly. So that's where the 21 milligram patch kind of correlates with the above the half pack a day. So that's where the 10 cigarettes is kind of a marker for the change in dose because it's a half pack a day. Right. So it wasn't just a random thing.
It's a lot of cigarettes.
It is. So as far as side effects that we can expect from the patches, skin irritation, obviously, because it's using the nicotine transdermally, you're going to irritate the skin, potentially sweating, nausea, vomiting can happen, especially if the patient does continue to smoke while wearing the patch, because it's going to be obviously more nicotine than their body's used to. Mood and sleep disturbances can be common as well. Muscle aches. The back hip can be a good spot to put the patch if the muscle ache starts to happen. It tends to be less likely to cause those. And then just some counseling points is for to tell patients that may be experiencing some insomnia or those vivid dreams with the patches, that they should take the patch off before they go to bed. And obviously if you're giving a patch, it's going to be still releasing that transdermal stimulant throughout the night, which is going to cross the blood-brain barrier and definitely can worsen dreams. So just taking the patch off while you're sleeping, and then applying the patch to a clean, dry, non-hairy area of skin, and rotate the application site to avoid that skin irritation that we talked about. You're also supposed to obviously not cut or break apart the patch, and the typical spots where they do it, the left or right upper arm, left or right side of the chest, on the back, or so the upper, right or left upper back or lower back is fine. And if you rotate sites, you got plenty to choose from, so hopefully you don't become too bothersome to the skin.
Yeah, as you can imagine, you want to avoid the center mass of your front or back, because those are going to be bending and twisting, and anywhere where there'd be a crease is probably where you'd want to avoid it. So even on the belly beside your belly button is not a place where they recommend. So you can imagine the upper back, upper chest, lower back are places where you're not going to get a whole lot of creases.
Yeah,
right.
I can't have anything getting in my way of sit-ups.
No. Sitting up to grab more chips
Right,
for me.
for sure.
Yes.
Yeah, me too. I used to do sit-ups.
Yes.
We go through the lozenges.
Yeah, so you also have the lozenges, which are obviously an oral option. They come in 4 and 2 milligrams, like I said, over the counter. You can also get a prescription and maybe have them covered, but they're very cheap. There's a recommendation about the dose as well and this is related to the first cigarette in the morning. So if your first cigarette is less than 30 minutes after waking, they recommend using the 4 milligram lozenge. If it's greater than 30 minutes after waking, they recommend using the 2 milligram lozenge. You place this between the gum and the cheek and allow it to dissolve slowly. So you don't do what I do with pretty much every hard candy, which is just suck it to death on the top of your tongue and then get annoyed at that and just chew it. You do not want to do that. So put it between the gum and the cheek, allow it to dissolve slowly. You can use one every 1 to 2 hours, no more than 20 per day. Adverse effects are related to it irritating the mouth a bit. Apparently, it's known for hiccups and heartburn. Also, nausea as well might be related to if you're also smoking while using it, or if maybe your dose is too high or something like that, or you're using it too often.
And the lozenges can be good because the patient can sort of titrate their dose if they're using it, especially if they're using it as like adjunct therapy for their cravings. But it's also an oral substitute for cigarettes, so that not necessarily hand to mouth routine, but just having something like you see people that quit smoking, they'll eat chips a lot or something.
Yeah.
And
Even
then,
people who don't smoke eat chips a lot, like me.
That is true. It's true. And then the lozenges can be added to a patient who's using the patches as kind of like their base therapy. So when they have situational cravings, they can use a lozenge to kind of handle that craving. Definitely easier to use than the gum in patients who have like dental work, dentures, things like that. Some of the disadvantages, and the main one to think about, would be just no food or drinks 15 minutes prior to using the medication, or obviously during use as well. But it can interact with the absorption of the nicotine, obviously.
And then there's the gum, and I'll tell you why it's a little more tricky, but it also comes in 4 and 2 milligrams, and those doses are similarly related to if you have your first cigarette within 30 minutes or after 30 minutes of waking. But this is totally counterintuitive to how you do gum in general, but you want to chew it briefly until you feel your mouth tingle. Then you park the gum inside the cheek until the tingle fades, and then you repeat. So you don't just leave it there. You take it back out, you chew it again until you feel it tingling, and then you park it again. Discard, and you do that for 30 minutes. So you discard it after 30 minutes. That's a lot of upkeep, in my opinion.
I'm not a fan of that.
I'm just so sure that the vast majority of people do not do that.
I would do the chew and park technique for 2 rotations.
2 seconds.
And then I'd go, I'm just going to chew this.
I'd be like, I'm just going to swallow it.
It's been 30 minutes already, right?
Right.
Spit it out.
But that's how you're supposed to do it, and that's probably how you get the best results and avoid side effects. But you're supposed to use 1 piece per hour with a max of 24 per day. Similar irritation in the mouth can also cause hiccups, heartburn, and nausea, and also jaw soreness from the chewing. I would chew gum all day when I'd work my retail shifts, and by the end of the day, my jaw was really tired, and I actually ended up with like a clicking in my jaw. Like all the time, anytime I chew anything, I would click. I had to quit gum.
Really?
I had to quit gum.
That's incredible.
I had to gum cessate.
That must have been terrible.
Yeah.
You use Varenicline? So as far as some advantages to the gum, kind of like with the lozenges, you can titrate the dose. They are a good oral substitute for cigarettes, obviously, and then they can be used with the patches for situational cravings. Same with the gum, like with the lozenges, no food or drink 15 minutes prior to or during use. And then, like Cole said, educating the patient properly to make sure that they're chewing with proper technique, and it can damage dental work, dentures, things, so just be aware of that if someone's just had recent dental work done.
Yeah. There's another option that I think is really interesting, and that's the inhaler cartridge that I mentioned, branded as Nicotrol, but it's a puff into the mouth or throat that you can use until cravings subside. It's not an inhaler. You need to counsel not to inhale into the lungs. but you can use one cartridge every 1 to 2 hours, and each cartridge contains 80 puffs. I don't know. I kind of like this because it gives you some flexibility, some customizability. It works really quick. So as you feel the craving come on, you puff it. It mimics that hand to mouth motion, kind of like taking a puff of a cigarette. I haven't talked to anybody anecdotally who used it, but I feel like this is a good option.
Yeah, so I had a patient actually just recently that I was talking to about smoking cessation, had already met with the primary care provider, started the process of getting on nicotine replacement. Then the first time I met with her was having breakthrough cravings, didn't want to do like vernicillin or any of that, wanted the nicotine replacement. So I had it on the gum that got, some improvement. She went from like a 3/4 of a pack down to a half pack, maybe a little bit less. But her big thing was that hand to mouth sort of habit, especially like in the car. And so I got her a prescription for the inhaler, and she loved that thing as far as like in the car and using it for that hand to mouth type of habitual movement. And she's like, this is great. I love it. And started weaning off even more like right away because she had that. So I've seen it where it'd be pretty useful in that situation, and didn't really have any problems getting it covered or anything, which was nice.
Nice. That's good.
So yeah, so mimicking that hand to mouth ritual, that's tends to be where I think of the usefulness in this one.
I think it is useful, and it can also cause mouth irritation or coughing if they take a pull too hard.
Yeah, they don't, definitely, like Cole said, do not inhale it like albuterol.
No.
The nasal spray is another formulation that's out there. So it's available as a 10 milligram per ml solution. So you get 0.5 milligrams per spray, and there's 200 sprays per bottle. So the dose is typically one spray in each nostril, and you kind of use the needed number of sprays every 1 to 2 hours with a max of 80 sprays per day.
Similar. That cartridge was 80 per cartridge.
Yeah, it's a lot.
That's a lot. And 80, I can imagine. Like I do Flonase sometimes when I am like some allergies. I couldn't imagine doing 80 nasal sprays.
It's a lot.
Yeah,
but your allergies probably are a little different feeling than what nicotine withdrawal.
I would imagine, yeah.
But same kind of thing. You can titrate the dose with this. The rapid delivery of nicotine, because it's intranasal, is definitely useful for some patients. Can be added to the patches, just like the other options can be. But it's definitely probably the most commonly cause of adverse effects compared to other nicotine replacement products. And some users just can't tolerate the nasal mucosal irritation that can happen from it.
Yep.
Bupropion.
So this is the other prescription oral option that's not Chantix. And as we go, we'll talk about which is preferred, but this is usually not first line. Chantix is usually first line. But Bupropion SR, branded as Zyban, is the one that's specifically approved for smoking cessation. The mechanism of action is believed to be that it blocks nicotinic receptors in the brain, interfering with reinforcing effects of nicotine, so it reduces the positive feedback cycle. It was kind of an accidental discovery because as it was being looked at for schizophrenic patients, which it didn't work in, they found that patients quit smoking. So nice. It's 150 milligrams once a day for 3 days. Then you increase to 1 tablet twice daily. And again, with the quit date, you start it 1 to 2 weeks prior to the quit date. So you schedule the date, you go ahead and get started on it beforehand. And it's not something that's really long term. It's used for 3 to 6 months during that portion to try to quit. Right?
Yeah. And I will say, unless the patient has concomitant depression, obviously, and would benefit from that.
You're killing two birds, as it were.
Yeah. So, and I don't know if you guys have ever heard anybody describe the way cigarettes taste while they're taking bupropion, but I've heard it described as basically like it makes their mouth taste like an ashtray, and so the taste of the cigarettes becomes really disgusting, and that's one thing that can obviously help, along with the dopamine regulation and all that. But also with bupropion, you get the appetite suppression as well. So in a patient who is worried about maybe their appetite going back up when they do quit, that can be a good option maybe for add-on therapy for them. But like Cole said, the FDA-approved version is the Zyban, so it's the sustained release formulation every 12 hours. The extended release, the XL, like Wellbutrin, the immediate release formulations are not approved, but it's if you can't get brand name Zyban and you can get access to other bupropion formulations, that'll be fine. If the patient doesn't see any benefit after about 7 weeks, they most likely can kind of change courses at that point, because only about 6 to 20% efficacy reported in the literature past that point. But it definitely can be useful, like I said, is like kind of adjunctive therapy if they do have some anxiety, or depression associated with quitting, or just as a, comorbidity, then it can be a benefit to those patients, even if it's not the main backbone of their therapy.
Right. And it does have some adverse effects associated with it that we generally associate with Wellbutrin. Insomnia, headache, dry mouth, possible convulsions, or at least increase, it lowers the seizure threshold, mood changes. So you'd want to use caution and probably not use it in a patient with a history of seizures, or use caution with head trauma, or a patient that binge drinks, or a patient with anorexia due to the potential weight loss.
All right. So the last thing we'll kind of mention is, this is not by any means a go-to option. You probably have exhausted your other resources first, but there is some data with nortriptyline, one of our tricyclic antidepressants. It's not FDA approved for smoking cessation, and it does carry the same box warning as any of the other antidepressants do. But, the side effects are usually one of the reasons why we try to avoid these in smoking cessation, even though there is some data that support its use. The orthostasis that can happen, the anticholinergic effects, again, the effects on dreams, the weight gain, sedation, increase, sweating, all those things make it a lot harder for patients to tolerate nortriptyline or any of the other tricyclics. Nortriptyline is a little bit better profile or adverse effect profile compared to like amitriptyline, but it's still something that a lot of people can't tolerate. So it's an option, potentially more of like a third line, fourth line option, but there is some data, like I said, with nortriptyline. Yeah.
So if you're thinking about this as far as what you're going to start with and what you might go to first line, we're thinking Chantix, or by itself or in combination with nicotine replacement therapy. I'd probably say just go ahead and combine it with some sort of nicotine replacement therapy.
I feel like most people now use combos.
I would use both.
I've even heard of some of the smoking cessation clinics that are using like triple therapy right from the start: bupropion, varenicline, nicotine replacement.
Oh, nice.
Just throw the kitchen sink at you.
I mean,
I get.
I don't really see a reason not to. And
right.
Just because, like, this is kind of, I think, unique in this sense, and this might just be my opinion, but just because the quit attempt wasn't successful doesn't mean you can't retry those medications next time. There might be a different reason, like the patient was like, no, that side effect did not work for me or something, but say that they did all the right things and the medication was fine. It's just that they relapsed. Like, why not? I think you can reuse it next time, right?
Yeah, and I think the concern with maybe with like the debate against doing multiple medications like that at once would be the compounding, side effects, or not knowing, is the nausea coming from dose or
that's a good reason not to use combo. But but at least for a second or third or fourth or additional quit attempts, it seems you could retry them
for sure. Especially if they've had success in the past, but they just kind of didn't stay with it, or whatever. I think that, or just use that option plus an augmentation option.
Agreed. So if you're going more conservative, Chantix plus NRT, then you could try bupropion plus NRT, or those by themselves. Might can consider Pamela after that, or some combination therein.
And the patient I was telling you about with that nicotine inhaler basically started off had already tried varenicline and was like absolutely opposed to using it again because the dreams were so bad. Wanted bupropion because it had had some success with that in the past just for depression. And so he started off with bupropion and the nicotine patches. She was smoking over a pack a day. And then that first regimen got down to a half pack. And then that's where the gum was added in as like just for breakthrough cravings. And then that got her down to, a little bit further. And then from there, the inhaler was taking it the rest of the way. Nice. So it's multiple, 4 drugs essentially at the end of it, but use it the appropriate time.
If you get there.
Yeah.
If you get there, that's what matters.
Yeah, exactly.
It's about
that's what I said.
It's about the destination, not the journey.
Is that
right?
I don't think so. I think there's some people that disagree.
How many
with that.
colloquialisms can we think of?
We can barely even say the word. So, anything else with smoking cessation?
No, I think we got it.
There's definitely a lot of good options out there. So for those of you who like and they need patient assistance. There's smokefree.gov. There's 1-800-QUIT-NOW. There's the Truth Initiative. There's several different, whether they be web-based or, group-based programs to assist patients in their road to quitting.
And there is some good data around quit rates, improved quit rates with good follow-up with either group support, individual support, telephonic support, that sort of thing. So
absolutely.
Good follow-up is important.
Yep. So that's all we got for you today, guys. Again, if you're already a free CE member, make sure that you use the code and go take the post-activity test to claim your credit. For those of you who want more like traditional style lectures and don't want our tangents and getting off topics like we do pretty much every episode, check out the Patreon because we have various pharmacotherapy lectures on there with the PowerPoint slides you can download and everything. So it's patreon.com/CoreConsultRx. If you have any questions for Cole or myself, reach out to us. The emails are in the show notes. You can text us directly at the number in the show notes or reach us on any of the social media platforms. And to say hey to our old friend and sponsor, Pearls, they have a new smoking cessation pharmacotherapy review that's on their app. So if you have not joined Pearls yet, go www.pearls.com/CoreConsultRx. And check out the app and all their great charts and algorithms. Their website just keeps adding more and more content. So check them out. But that's what I got. It's great seeing you, everybody, again, or listening to us talk or something like that. Great hearing you guys in spirit.
Interacting with you over podcast. We did hear from some people live.
That's true, yeah. So I wasn't totally off base.
No.
Anyways, see you guys later.